Before we dive into specific STIs, we need to establish a common language and understand two fundamental concepts: definitive tests, window periods. A definitive test is the gold standard. It's the most reliable method science has to confirm whether an infection is present or not. This is important because there are many tests out there, including rapid tests, older, less sensitive ones, that might be used for screening but require a more accurate test for a final diagnosis. A definitive test looks for the germ itself, its genetic material, DNA, RNA, or for the specific antibodies your immune system creates to fight that exact invader. The window period is one of the most critical yet misunderstood concepts in STI testing. It refers to the time between when you are first exposed to an infection and when a test can accurately detect it. During this period you could be infected and even be able to transmit the infection to others, but a test might still come back negative. This happens because it takes time for the virus or bacteria to multiply to a detectable level, or for your body to produce a measurable amount of antibodies. Testing too early within this window can give you a false sense of security, which is why knowing the correct timing is essential for an accurate result. Think of it this way: if you plant a seed, you can't dig it up the next day and expect to see a full-grown plant. It needs time to sprout. Similarly, infections need time to sprout in your body before a test can find them. Each STI has a different window period, ranging from a few days to several months. Human immunodeficiency virus, or HIV, is a virus that attacks the body's immune system, specifically the CD4 cells, T cells, which help the immune system fight off infections. Left untreated, HIV can lead to acquired immunodeficiency syndrome, AIDS. Thankfully, with modern medicine, HIV is a manageable chronic condition, but early detection is the key. The best and most common initial test for HIV is the fourth-generation antigen/antibody combination test. This test is superior to older antibody-only tests because it looks for two things: HIV-P24 antigen, a protein from the virus itself, antibodies your body makes in response to it. The antigen appears sooner than antibodies, narrowing the window period. The sample required for a fourth-generation test is a small amount of blood, usually drawn from a vein in your arm. The process is quick, just like any other routine blood draw. There are also rapid versions of this test that use a drop of blood from a finger prick and can provide results in about 20 minutes. If a rapid test comes back positive, it is considered a preliminary positive. It is crucial to understand that a rapid test is a screening tool, and the lab-based test is the definitive confirmation. The window period for the fourth-generation antigen/antibody test is significantly shorter than for older tests. The P24 antigen can be detected as early as 2 weeks after exposure, and most people will have detectable levels within about 18 to 45 days. To be absolutely certain of a negative result after a potential exposure, the Centers for Disease Control and Prevention recommends testing, and if negative, retesting at 3 months. A negative result at 3 months post-exposure, assuming no other exposures in the interim, is considered conclusive. If you receive a confirmed positive HIV diagnosis, the first step is to connect with a healthcare provider who specializes in HIV care. This is not a death sentence. You will start a treatment regimen called antiretroviral therapy, ART, which involves taking daily medication. ART works by reducing the amount of HIV in your blood, your viral load, to a very low, undetectable level. When your viral load is undetectable, you can live a long, healthy life, and you cannot sexually transmit HIV to a partner, a concept known as undetectable equals untransmittable, U equals U. It is also vital to inform any recent sexual partners so they can get tested and seek care if needed. HIV, syphilis, chlamydia, gonorrhea, HPV, herpes, hepatitis B. Syphilis is a bacterial infection. It's nicknamed the Great Pretender because its symptoms can mimic many other diseases. It progresses through distinct stages if left untreated. Visual diagram: the 4 stages of syphilis, primary to tertiary. Early detection and treatment are vital. In late stages, syphilis can cause serious permanent damage to the brain, damage to the nerves, damage to the eyes, and damage to the heart. The definitive way to test for syphilis is through a blood test. There isn't just one test, it's a sequence of tests. Screening often starts with a treponemal test, TPPA, EIA, or a non-treponemal test, RPR, VDRL. A 2-step process is typically used to get a clear diagnosis. If a treponemal screening test is positive, An RPR is done to confirm active infection and establish a baseline. The RPR measures the level of antibodies your body is producing. That level, the titer, helps doctors see if treatment is working. The titer should fall after successful therapy. The sample for these tests is blood taken from a vein in your arm. The window period for syphilis can be tricky. The bacteria needs time to establish itself and your body to mount an immune response. Generally, a blood test becomes reliably positive about 3 to 6 weeks after infection. However, it can take up to 90 days in some individuals. If you have a sore, a chancre, that's the hallmark of primary syphilis. A doctor can take a fluid sample from the sore and examine it under a special dark field microscope for the bacteria. That can provide a diagnosis before blood tests turn positive. If you test positive, the good news, syphilis is completely curable with antibiotics, most commonly with an injection of penicillin. The stage of infection determines the dosage and duration of treatment. It's essential to complete the full course and avoid sexual contact until your doctor says you're not infectious. Chlamydia and gonorrhea are two of the most common bacterial STIs, and they often travel together, so, doctors frequently test for both at the same time. They are often called silent infections because the majority of people who have them, especially women, experience no symptoms at all. When symptoms do occur, they can include unusual discharge, pain during urination, or pelvic pain. The definitive and most highly recommended test for both chlamydia and gonorrhea is the nucleic acid amplification test, or NAAT. This is a highly sensitive molecular test that detects the genetic material, DNA-RNA, of the bacteria. The sample collection for a NAAT is simple and non-invasive. For women, the preferred sample is a vaginal swab, which you can often collect yourself in the privacy of a bathroom at the clinic. It's as easy as using a tampon. A urine sample is also an option, though the vaginal swab is slightly more sensitive. For men, a urine sample is the standard. If you have engaged in oral sex, it is crucial to tell your doctor, as swabs can and should be taken from the throat. If you have engaged in anal sex, it is crucial to tell your doctor, as swabs can and should be taken from the rectum. Chlamydia and gonorrhea can infect these sites. A urine test alone would miss them completely. A genital test alone would miss them completely. The window period for NAAT is quite short. These tests are so sensitive that they can often detect the bacteria within a few days of exposure. However, to be certain and avoid a potential false negative, it's generally best to wait at least 1 week after a potential exposure before getting tested. Testing earlier than this might not give the bacteria enough time to multiply to a detectable level. If you have symptoms, you should get tested immediately, but if you are testing after a known exposure without symptoms, waiting that week will give you a more reliable result. If your NAAT comes back positive for chlamydia, gonorrhea, or both, treatment is straightforward with antibiotics. Chlamydia is typically treated with pills, while gonorrhea now requires an antibiotic injection due to widespread drug resistance. It is imperative that you take all medication as prescribed and avoid all sexual activity for 7 days after you, and your partner have completed treatment. You must also inform any sexual partners from the last 60 days. Section 6. Human papillomavirus, or HPV, is the most common sexually transmitted infection in the world. There are over 200 types of HPV. Some are low risk, they cause genital warts. Others are high risk, they can cause cancer, most notably cervical cancer. When we talk about HPV testing, we are almost exclusively talking about screening for cervical cancer risk in people with a cervix. There is currently no FDA-approved routine screening test for HPV in men, and none for detecting HPV in the throat or anus. Research is ongoing. The definitive test to detect high-risk HPV types on the cervix is the HPV DNA test. This test is often performed at the same time as a Pap test, co-testing, or sometimes as a primary screening test on its own. The sample is collected during a pelvic exam. A healthcare provider will use a speculum to view the cervix, then use a small, soft brush to collect a sample of cells. The sample is sent to a lab to test for DNA from high-risk HPV types. A positive result does not mean you have cancer. It means you have a virus that increases your risk and needs closer monitoring. There is no defined window period for HPV like there is for other STIs. The virus can behave very differently. Your immune system clears most HPV infections on its own within 1 to 2 years. The HPV test is meant to detect persistent infections that could lead to cellular changes, not brand new exposures. Routine screening usually doesn't start until age 25 or 30 for most people. When screening is done, it's repeated every 3 to 5 years, not after every new partner. Genital warts are usually diagnosed by a simple visual inspection by a provider. If you test positive for a high-risk HPV type, do not panic. Your provider will explain next steps based on your results, age, and history. That might be a repeat test in a year, or a colposcopy, where the cervix is examined more closely. The most important thing to protect against HPV-related cancers is vaccination. The HPV vaccine is safe and highly effective against the most common high-risk types. Herpes simplex virus, or HSV, is a common virus that causes sores, typically around the mouth, HSV-1, or genitals, HSV-2, though either type can infect either location. Testing for herpes can be confusing. It's essential to use the right test at the right time. If you have an active sore or blister, the absolute best, most definitive test is a PCR swab. A healthcare provider will swab the fluid from the sore. PCR looks for the virus's genetic material. It can accurately identify HSV-1 versus HSV-2. This is the gold standard for diagnosing an active outbreak. Blood tests, type-specific serologic tests, are also available. These look for IgG antibodies your body makes. It must be a type-specific IgG test. That distinction lets labs tell HSV-1 from HSV-2. A positive blood test means past exposure and infection. It cannot tell when you were infected or if current symptoms are from herpes. Section 8. Hepatitis B is a serious viral infection that attacks the liver. It can be a short-term acute illness or develop into a long-term chronic infection that can lead to cirrhosis or liver cancer. It is transmitted through blood, semen, and other body fluids. The great news is that there is a very effective vaccine to prevent it. Testing for hepatitis B is done with a blood test, but it is not just one test. It's a panel of 3 different tests that, when read together, give a complete picture of your status. This is often called the hepatitis B panel. The 3 parts of the panel are HBsAg, hepatitis B surface antigen, anti-HBs, hepatitis B surface antibody, and anti-HBc, total hepatitis B core antibody. HBsAg is a protein on the surface of the virus. If this is positive, it means you have an active hepatitis B infection. Anti-HBs is a protective antibody. If this is positive and the other 2 are negative, it means you are immune to hepatitis B, either from vaccination or from recovering from a past infection. Anti-HBc is an antibody that appears when you are infected or were infected in the past. It indicates exposure, but not necessarily immunity. The window period for hepatitis B testing can vary. The HBsAg surface antigen is the first marker to appear in the blood and can usually be detected 1 to 10 weeks after exposure. For this reason, it is the primary test used to diagnose an active infection. The antibodies take longer to form. If you are tested too early, all 3 parts of the panel could be negative even if you have been infected. If a recent high-risk exposure is suspected, a doctor may recommend testing immediately and then again in a few months to be certain. If you test positive for an active hepatitis B infection, HBsAg positive, your doctor will order further tests to determine if the infection is acute or chronic and to assess your liver function.